So hi everyone, thank you so much for coming to this webinar about internal medicine training this evening. My name is Anna. I'm an IMT3 based in Liverpool. So I've been through this process just like you 3 years ago. So I know, how anxiety-provoking it can be. But I hope that this webinar allays some of your fears around the interview process. I'm not going to be talking much about what internal medicine training actually involves, because if you come to the stage, you probably already have a good awareness of what the program is going to entail. I'm just going to let my colleagues from Mind the Bleep also introduce themselves now.
So hi everyone, I'm Jake. I'm an FY1 based in Edinburgh at the moment, and I'm sort of under the Mind the Bleep medicine team.
And I'm Anush, I'm one of the F2s. I'm in Liverpool at the moment. I run the medicine subsection of Mind the Bleep.
Thank you. Okay, so the first thing I want to say is, if you've come to this webinar, I presume that you've got an interview. So congratulations on this incredible achievement, because IMT has suddenly become incredibly competitive compared to when I applied 3 years ago. And the fact that you've got an interview means that you probably got quite a lot on your CV, or you've got plenty to talk about. So hopefully the interview should actually be quite a good way for you to show off everything that you've done. Now the interviews are online. It is quite a different experience. Back in I don't want to sound like someone who's archaic, but when I had my interviews, we would go to a center and have to have our big heavy binders and go around different stations. But the online interviews feel a bit more like a conversation, and you'll be talking to the same people throughout. It's only, the entire interview lasts less than half an hour, so it's going to go by incredibly quickly. So I think the important thing to remember is, no matter how you feel the interview went, retrospectively, you probably be criticizing yourself about lots of things. Just remember that, it's not a reflection of you as a person. It's a very artificial setting. And, there's no way anyone can get a full picture of you as a trainee from, this kind of interview length. So you just have to learn to play the game. And today we will talk about the structure of each station and how you might want to structure your answers. So the first station is about you and about your portfolio and just you as a person. So to some extent, you do have the most control over the station, and it is also worth the majority of the points for the interview. So I would suggest that you probably want to spend the most time preparing and practicing answers for this station. If you haven't found someone to practice with, I would highly recommend that you do before the interview. It doesn't have to be a medic. It can just be, family member or a friend. But you do need to at least practicing talking about yourself. And it is awkward, but you have that. It will make things sound a lot more natural when it comes to the actual interview, if it's come out of your mouth at least a few times. So it's going to start with a 2-minute narrative. By the way, sorry, if anyone has any questions, Jake is gonna let me know. So feel free to ask questions throughout this. And, I do want this to be interactive. I know it's difficult when it's online, but feel free to ask questions throughout. So the first 2 minutes are going to be a narrative about yourself. So it's timed. You don't have any props or aids. You should prepare like a few key points. I wouldn't necessarily memorize what you want to say verbatim, because that you risk sounding a bit unnatural. But you should have a very select number of things that you want to mention, ideally that are internal medicine focused. There's no way in 2 minutes you can discuss your entire portfolio. It's not possible. This will then be followed by 4 minutes of questions about, that might be lifted from your application. So anything that you've mentioned on any of the sections in your application, you should be able to discuss at more length, and you should prepare for that. So it's really important. The scoring is actually really crucial because basically your entire IMT application is scored on your interview. Station 1 is scored by the two interviewers after 5 possible marks. So if you look at the mark scheme, 1 mark is, so in the very middle, if you score 3, you're performing at the level expected of an F2. And 5 is, exemplary performance, well above that level. And 1 would be, not, performing well below. So there's going to be 2 people scoring out of 5 on 2 different domains. So each interviewer will score you out of 10. And this will then be weighted at times 1.6, so 16 marks each. So accounting for 32 points out of 60 points from the entire interview. So this station really is half your entire interview, even though it's only 1. So it really is where you should be putting a lot of your focus. And it'll probably be where, now that it's all online, you will have your stations in order. So, if this station goes well, it does set the rest of your interview up to go quite smoothly, I would say. And it gives a good impression to the interviewers, although I wouldn't panic if you feel it doesn't go well. And you also get some points for communication across all stations. So in terms of planning, it's entirely up to you how you want to do it. You can either talk about your achievements in a chronological fashion, undergraduate, as a foundation doctor, as a fellow, or whatever you've been doing. Or you can divide it by your academic achievements or your clinical achievements, QI and research and that kind of thing. There is a person specification for the IMT application. So that has some of the qualities that they're looking for in candidates. So you probably want to lift from that and talk about some experiences you had that show that you can manage an acutely unwell patient, you can prioritize, you can delegate, you can work well in a team, and do research on top of that or quality improvement. I mean, to be honest, in my opinion, I do think they expect a lot of trainees because it's not enough just to do a good job in a full-time job, but you have to do all these other things. But I'm sure you will all have things you can talk about at more length. So possible ways to structure include talking about exams. MRCP is something you probably is worth mentioning if you've started doing that. Research and publications. Any leadership roles you've had, as an undergraduate or as a postgraduate. Ideally medicine linked, but not necessarily. And you want to link it into how it's affected you as a person and what kind of skills you've taken from that. Quips and teaching. So hopefully you've all had opportunity to do at least some of these things, not necessarily all. 2 minutes is quite short, so I'd probably max pick 4 things to talk about with half a minute on each. So here are some examples. Just going to go through them. So I'm just going to allow you to read these examples. So as mentioned before, you might want to structure them by domain. So this is just a very common interview technique that is used. And you might want to have maybe 4 things you want to discuss, and you can use the STAR framework. So you might say, I was, tasked to do, to manage the acute medicine rota, and this was, then you want to explain your role in that and how you did it, how you contacted people, maintained a spreadsheet, or whatever you did, and what the result was in terms of any organizational skills you got out of that. And then the questions after that are pretty variable, but are usually about the same kind of themes. So what can you evidence as commitment to IMT training, MRCP, any conferences you've been to? You probably will get asked about quips and audits, any academic presentations. And you might get asked, what your future career aspirations are as well. You might not necessarily have an idea of what specialty you want to do, and I think that's completely reasonable to say. And yeah, I mean, how you decompress is really important as well, because medicine is just getting it's incredibly stressful, and the workload has significantly increased in recent years. So I guess here this is a question about what qualities can you demonstrate are essential to being an internal medicine trainee. So these are really about your soft skills and generic skills, which are really important. And communication, which they're scoring throughout your interview, is probably one of the most important attributes of a medical trainee. And quip and audit. Does anyone have any questions so far?
No, nobody's posted so far.
Okay. Okay, so just some key takeaways is you want to be quite concise with what you select in the 2-minute period. It is really short, so you should time yourself and make sure that you can finish it within 2 minutes and not having to cut you off. And if you haven't seen the person specification, do I have it saved up here? Probably don't think I left it up, but just continue. Okay, so the second station is the clinical scenario. It's not going to be something that's really out there. It's going to be something fairly standard, and you will be fine. Keep it simple. It's just basic management, basic initial management, and showing that you're a safe doctor. So it's going to be 3 minutes of preparation time. So you might want to think about, so that you will get a bit of a short vignette. You might want to think about any questions you want to ask, any investigations, your differential, and your management. And you might want to also consider which other specialists you want to involve. Then there's going to be 8 minutes of questions about the clinical scenario, followed by a 1-minute SBAR handover, which is also something that was introduced last year. So the way it's scored is, again, out of 5 marks, and you're scored on investigations, diagnosis, and management, and then your handover separately. So that accounts for 20 points out of the 60. I don't know if is it a quarter of the whole interview then, or is it a third? I think we need to double check that. So the vignettes tend to be quite short, so a few sentences. It's not going to give you all the information in the scenario. And you need to kind of structure and mentally prepare yourself at this time. So think about what further information you would like to gather and what next steps would you take, your differentials, possible interventions and treatments, particularly initial management, and any kind of wider aspects of the scenario which might involve a communication with the patient, DVLA kind of guidelines or end-of-life care discussions or that kind of thing.
Anna, we've just got a few questions actually, and this is quite good. During this station, obviously you've got your 3 minutes to prepare. Do you know if the sort of individual's able to jot down sort of notes on paper, or is it all mental preparation?
In my time, yeah, we did have. I mean, I think the difficulty is this is all going to be online, but I'm fairly sure you can jot notes.
Okay.
Yeah.
I just know it's the presentation bit in the station one. You can't have any sort of notes or any kind of PowerPoint. That all has to be verbal. But yeah, this one, the 3 minutes, you've got to read the sort of clinical scenario. You can jot down some notes. Yeah.
Yeah.
Thank you.
Okay. So this is an example we've come up with just to go through what a potential scenario might look like. So this is quite, straightforward. A 19-year-old guy, a gentleman with a background of epilepsy who's brought into A&E with coming with a seizure that was witnessed by his family. So the first question is, how will you assess this patient? I don't know if we can make this interactive at all, or if anyone wants to just kind of jot anything down about what is the main what does your interviewer definitely want to hear you say in this kind of scenario.
Someone said ATE assessments.
Yeah, 100%. And I think certainly if your scenario might not necessarily be this acute. For example, I had a patient in my interview. It was a patient coming in with infective endocarditis, and I think he was relatively stable. So I had you have a bit more time. But this guy is like actively seizing, so you do have to just jump in and do an ATE assessment. So, I think it's really important when you're doing A2E to say that if you're taking the lead in the scenario, you want to delegate responsibilities to other members of staff. So you make sure someone is looking after the airway. You'd call for help. You get someone to ensure the patient has IV access, and someone checks, blood glucose. So general A to E is fine, but in a seizure, the most important thing is you want to make sure the patient is safe, the airway is preserved. You check the glucose, and also make sure you have some emergency treatment on board. So even if the patient doesn't require benzodiazepines, it's still worth asking a nurse to go and get some, just in case it's required. So going through the A to E. You might say to the interviewer, I would start by doing an A2E assessment. I'd make sure the airway was patent and use airway adjuncts if required. I would then move on to breathing, make sure he is on oxygen, and perform a blood gas as well. I'd ask a colleague to examine this patient. Circulation, I would ask another member of staff to gain IV access, bloods for electrolytes, inflammatory markers, and a gas as well. Check this patient's GCS and pupils, and then again, do external examination.
Anna, we've just got a couple of questions. So just with, you talking through A to E, is it possible that you could be handed some kind of results to interpret?
I was during my scenario.
So you could be given, sorry.
Yeah.
Go on, sorry.
No, I did get further results, like blood tests and that kind of thing during my particular scenario. Yeah, I mean, certainly in this kind of situation, you might get perhaps like a CT head report or something like that. Or they might, but I think in this situation, what's more likely is they'll ask you, what are you going to do next if he continues to seize? And maybe testing management, and then how you might want to investigate why it's happened.
Sure, thank you. And just sort of on that note of management, somebody's asked about sort of covering clinical scenarios in preparation for this station. would you say it's predominantly sort of medical emergencies that you would find in, say, like the Oxford Handbook, you know, the emergency chapter, or kind of how thorough do you think people need to be for this station?
So yeah, I use the Oxford Handbook in my preparation, but I don't think infective endocarditis was in that. And I had a friend who had management of hypertension,
Okay.
and talking through primary and secondary causes. So unfortunately, I don't think you can prepare for every eventuality. I think it is, you know, it's so broad. Like medicine is extremely broad.
Yeah.
You should be prepared for, if it's not going to be something that you know nothing about, and if you really don't know anything about it, I think just showing that you're safe, you're acting safely, and seeking advice from
Yeah.
seniors is fine.
Perfect, thank you. And somebody's just to clarify, so because it is an interactive scenario and you're obviously speaking to the examiner and they're giving you information, so say like you'd say I'm going to do an A to E, and you get to the B section, and would the examiner then give you, say, like their observations, like their rest rate and their oxygen sat, so they'll give you that sort of as you work through it?
They may well, as soon as you say A to E, they may well interrupt you and say, "Fine, you've done this A to E assessment.
Right.
This is what happens next." Because there might be specific things they want to get out of you.
Sure.
But I think if you mentioned that you would do A to E, and they said that's fine, move on.
Yeah.
Be prepared to get your spiel might be cut off at that point.
Great, thank
You
you.
might not necessarily get to discuss exactly what you want.
Yeah, but you're just demonstrating that, which is obviously the important thing. But yeah,
Exactly.
thank you.
This is a question you might get asked. So what are the possible causes of this man's seizures? So he's 19 years old. He has a background of epilepsy that's diagnosed, for which he's on treatment. So I think one of the first questions you want to ask is he actually taking it? Is there a metabolic cause that's, predisposed him to seizures, such as, infection or alcohol or sleep deprivation, whatnot? So those are your kind of primary causes. But when it comes to secondary causes, you won't go wrong. And this, aside from seizures, I think generally in most areas of medicine, you won't go wrong if you mention vascular, inflammatory, neoplastic, or infectious as broad categories in your differential. Yeah. So certainly, if this had been, a 60-year-old who had no background of epilepsy, you'd be more worried about a CNS infection or an SOL that's causing his seizures, or a vascular event like an acute bleed. But it's really the context is really important. But I don't want to get, obviously we're talking about how you want to structure answers. So I would say if you're talking about differentials, use the surgical sieve. It is useful. So how would you further investigate this patient? So does anyone want to maybe pop some suggestions in the chat box? Oh,
I can let you know if yeah.
Yeah, that's probably for the best. Yeah.
Would you be able to? Oh, Anna, if you you see the box at the bottom, if you just click hide.
Oh yeah, okay.
It covers some of the perfect. Thank you. So blood. So you would want to do, as you said, rule out electrolyte abnormalities, infection, CT head. Somebody said an EEG and an LP.
Okay. So yeah. Okay. So I think bloods is definitely key. Would you necessarily do a CT head?
Yeah.
Say it's a 19-year-old and he's just not taking his medication, and after following the seizure, you examine him and he's GCS 15, and there's turns out that he just wasn't taking his tablets. A CT head might not necessarily add anything. Certainly, if he showed other signs, meningism, or he's confused, or there's something atypical in the history and he's not recovering as he should, you
Yeah.
might consider a CT head. If he's banged his head, had some kind of injury, you might want to consider that as well.
Yeah, good. Somebody said if this is the first seizure, so you could say that to the examiner. Yeah, you want to know if this person has a background of epilepsy, because that, I know, if it's a first presentation of a seizure, that can change things, can't it?
Yes, exactly. So if it's the first presentation, I would want to do a CT head to rule out an organic cause for his seizures. Yeah. It may be that this is first presentation of epilepsy, but I would want to exclude alternative causes. EEG, I think, is probably not something that you'll be able to access on the acute take. It can be useful like in the outpatient setting. And I would say I would refer this patient to a neurologist for consideration of further investigations, such as an EEG. I don't think it would be in your initial kind of steps.
And somebody just said an ABG and a chest X-ray, which I suppose for completeness.
Yeah, absolutely.
Yeah.
And what would you expect to find on the arterial blood gas?
Somebody said high lactate.
Mm-hmm.
Yeah. Could be hypoglycemic. That's actually really, yeah.
Yeah, absolutely. So ABG is very useful, can show you a lot of other information. But typically with a seizure, you have a metabolic acidosis with a high lactate that actually typically resolves quite quickly following the event.
Great. Yeah, everyone's saying, yeah, lactate.
It also has a glucose on the gas as well. But you should just check a glucose anyway. But yeah, it's good to know.
Great. Thank you.
But certainly, this is post-seizure in terms of examination. I don't think you'll be able to examine the patient if they're actively seizing. Although it is important to document what the seizure looks like. Lung puncture is quite important. Now, that's an investigation you will be able to access acutely. So your management is really going to depend on what the information they give you. Who might you call if this patient is seizing, uncontrollably?
Double two, yeah.
But you're an AD in this scenario, so would you call 2222?
ITU, the med reg.
Yeah.
Anesthetist, yeah.
Yeah, cool. Anesthetics is pretty key here for airway management, and but we'll go through some of the treatment procedures as well. So yeah, I mean, gathering information, has this patient, so when you're gathering information, you want to know, does this patient have a background of previous seizures and what treatment he takes for that? And has he been concordant with that? And has he had any treatment in the community prior to arrival? And yeah, so basically if it doesn't terminate after 5 minutes, you want to give IV lorazepam, or IM midazolam is another option, or you can give buccal midazolam, and I think rectal diazepam. But in practice, you should be able to get access. And in my area, the second line is usually IM midazolam. But I would probably mention I would go by the status epilepticus guidelines you have locally. The first line management is a benzo, so you normally give lorazepam 4 milligrams, and then wait for 5 minutes. And if it still hasn't self-terminated, give a second bolus, and then wait for 5 minutes. And at that point, you want to think about loading the patient with an alternative agent such as phenytoin or valproate or Keppra. I have to say that if the patient is really seizing for more than 5 minutes and it's not self-terminating, I think anesthetics should be there already, because it might be that they need airway protection, and also potentially sedation as well.
So just to clarify, Anna, just because a few people had put 2222, so if you're getting to, you know, someone started the timer and it's getting to say 4 minutes and this person is still seizing, would you then think, could you then say, I'll put out a medical emergency 2222 and we need an anaesthetist there as well? Like, would that be?
You can. It doesn't happen often to A&E, but
Oh, right, so it's A&E, yeah, you've got consultants.
but you should fast be the anaesthetist. A&E,
Right.
there should be registrars and consultants around.
Sure, yeah, yeah.
But I think to say that you would seek senior advice and possibly the anaesthetist is good. But obviously, this might be a patient on the ward who's already been admitted and is then seizing, then it's a different scenario. If they're on the ward, then you should put 2222 out, and that would be entirely appropriate. So we've talked about this. This is kind of beyond the realms of what you will be able to achieve, but the anesthetist should hopefully be able to sedate the patient at this stage if you're getting to this point. And here I'm just talking about some complications of status. Yeah, so it's really important because just for neuroprotection to terminate the seizure as quickly as possible. So this is kind of like, you know, exploring your different knowledge of your different areas of knowledge in terms of long-term management of patients with epilepsy and seizures. So DVLA guidance is pretty important. So don't forget those kind of wider aspects of care. Anyone have any idea about how you might respond to this question?
Someone said no.
So so what would you do?
First fit clinic after the second seizure, discuss with the patient. I suppose it goes back to, you know, you would say if you were unsure, neurologist, you would refer to a neurologist or seek advice maybe. But yeah, people are saying the first.
I would have those generic kind of fallback phrases like, I would seek advice in this situation, and but yeah, first fit clinic is entirely appropriate, and you know, kind of treat any provocative factors. So, you know, if they took like a bunch of ketamine and had a seizure, then you just, that's a very different scenario. Yeah, the short answer is no. So in terms of handing over this patient, we just wrote like an SBAR example. So I'd like to make you aware of this 19-year-old male. So let's say, for example, you're handing this patient over, you've seen them in resource, and then you've gone to medical handover, and you want to let your night colleagues know about them. I'd like to make you aware of this 19-year-old male currently in resource, admitted with a seizure. He has a background of epilepsy, diagnosed 2 years ago, for which he takes sodium valproate. He has recently been unwell with a flu-like illness and has been non-compliant with his medication. So on the first seizure was reported to have lasted 2 minutes and was self-terminating. The second seizure lasted 90 seconds and was also self-terminating, and was witnessed by staff in A&E and was tonic-clonic in nature. On examination, currently he's post-ictal. He has a GCS of 14. However, he's maintaining his airway without support. He's tachy, hypertensive, and saturating 93% in oxygen. Gas shows a metabolic acidosis with a raised lactate, and he's normal glycemic. We've sent bloods for FBC, electrolytes, and inflammatory markers, and also requested a chest X-ray. And he has had a start of his evening anti-seizure medication. So I'd be grateful if you can review this patient and also keep an eye out for his bloods and chest X-ray. If he has another seizure, he may well need discussing with neurology and loading with an anti-epileptic agent or IV lorazepam. So sorry, this, I think we written here putting out a 222. But if he's still in recess, that might not be appropriate. So, I mean, you know, you can, the clinical scenario really could be anything. But this is just an example of what an SBAR handover might look like. Do we have any more questions at all about this, or?
Nobody's put in. And just to clarify, you have a minute for that, don't you?
Say again?
The handover is just 60 seconds. That's all you're allocated for.
Yes, I think that was the case. I'll just double check.
Yeah, it was. Yeah.
Yeah. So you've got, I suppose it's about just trying to remember as much as you can, and then being, you know, succinct and concise. But yeah.
And I think, you know, I don't know if anyone is using resources to look for particular like examples, but I think, you know, there are resources out there, certainly more than there were a few years ago, to help you prepare for the interview. And you know, I think MediBuddy is something that I know quite a few people using, and certainly if I had access to that, I would have used that. But there are quite a few resources out there.
And someone's just asked, will you be given time to prepare for the handover? So from what we read, I believe it's just you finish your scenario and then you go straight into the minute of, yeah.
Yeah.
Are we allowed to take notes during the interview scenarios?
I'm sure you can, but I think it might interfere with your flow, potentially, because you'll probably be expected to answer questions alongside that.
It's a bit like an OSCE, but not examining. There's no one physically there, like a dummy to examine, but you're kind of talking through things, aren't you? So you want to keep focused. And can you tell us the resources?
I imagine it's probably going to be quite difficult to take notes during the actual interview process.
Yeah. So just touching on resources. So you were saying you would have found a kind of bank of scenarios useful to prepare with, and you said a MediBuddy. So because somebody said, can you tell us the resources? Did you use anything when you were preparing for your IMT?
No, not really. Like, I think I just used the Oxford Handbook, and I went through everything in that. I wish I had more to use at the time, to be honest. I mean, I haven't really used MediBuddy myself, but I used it when helping someone prepare for her surgical interviews.
Okay.
That was quite good.
Fine. And the thing is, I think please suggest the resources. I think at work and things, people will be doing SBAR handovers, you know, referring to different specialties and things all the time. So I think it's just, from what you've said here, it's just making sure that your handover is really focused and it's addressing the pertinent details, because the examiners can't expect you to remember everything. But as long as you're, as you were saying,
you always need to, you know, a good SBAR, you're going to start out with an actual request. Because you don't want to be going through, you know, all this stuff, and your colleague is just thinking like, what do you want me to do with this? You want to start out with, you know, I need you to do this, and this is the situation, the assessment, and what we need to do in next. Like, it has to be quite. You need to make it quite actionable. I would say that's what a good SBAR is.
So you would say, you know, I'm calling to ask for a review, please, of, and then you go and say a 19-year-old male, and you know you want to grab their attention, and especially if you've only got that minute, you want to get that across.
Yeah, you want to be like, you know, I'd like to seek some further advice regarding this 19-year-old male who's come in with a seizure, or you know, just what are you asking? Like, are you asking for advice about management, or do you want them to come and review some tests? Like, are you handing over to a different shift? Yeah, I don't actually know like whether they're going to make it clear like who you're handing over to, because that does have quite a big impact on how you're going to frame it. But I don't know if you guys know or have.
I think often like they'll tell you who you're handing over to, so it's like a senior colleague.
Okay. Oh, it could be like, say, for example, ITU, right? So if the scenario could have gone in you know, gone south. He may not have had a self-terminating seizure. He may have, continued to seize despite treatment and has just been loaded on Keppra. And you might be on the phone to ITU. So now that's a very specific conversation about, I'd like to discuss potentially, I'd like to refer this patient for potential intubation, ventilation, and sedation. This 19-year-old gentleman with a background of epilepsy who's currently presented with refractory status epilepticus. And that immediately is going to make, ITU be, take notice, because you've asked them for specific organ support. Obviously, your scenario might not be something this acute. It might be something that's, it might be that, it's someone with endocarditis and you're talking to microbiology about the case and you want some advice regarding antibiotics. But I haven't actually had experience about the SBAR. So I don't know. Do you guys know, has anyone told you what kind of examples of who you might be handing over to?
From having to look around it, it's often to the medical registrar.
All right, okay. So it's often to the senior colleague within the team. Okay.
And they also don't stipulate, they just say hand over. So I think it's a bit up to you and how you do that. But certainly SBAR, from medical school, you're taught, it hits the points. But I think what you were just saying, it's really important that you were almost having that headline statement at the beginning, like I'm calling for this, or even if it is just microbiology and you're asking for antibiotic advice, stating that, because then it gets it across that you know what you're kind of asking.
Yeah, exactly.
Yeah.
If it is often going to be the medical registrar, I think even just saying that there's a really acutely unwell patient that I think you should be aware of and that I think would benefit from a review is fine. Even if the reg is not going to add anything to your management plan, because you may well have done everything that they would have done. Yeah.
Great, thank you. I don't think there's
or this patient is deteriorating actively, and I'm worried, and I think I need some advice regarding management or something like that.
And I suppose you, Anna, as a med reg, if an FY1 is calling you or an FY2, when you're busy and you're rushing around and you've got a list that's just ever growing, you want the important things, don't you?
Yeah.
When somebody's
you definitely want to hear what I would if someone says I want you to review this patient, that automatically I'm gonna come review them, and I just want the key points. But it's hard when someone goes through something a big preamble and it turns out to be about a question about, say, their medication and you could have just got to that in the first place. I think it's helpful listening to someone who has a specific question.
Okay, thank you.
No worries. So the last station is about ethics. I think it's really short, actually. It's is it up to 5 minutes? Just kind of double check that's correct. It's up to 5 minutes in total.
That's what the IMT website says. Yeah, so I'm guessing it will be pretty much 5 minutes. But yeah, it's a single question.
Right. Okay. So is it? So in my time it was actually a scenario, but I'm guessing it's not going to be a scenario anymore.
I think it can be presented as a kind of situation. I think there's an example that we've put in the slides, actually.
Oh, yeah. So this is, again, scored out of 5 on one domain. So that's going to be 10 and then weighted again at 1 times 1.6, so a total of 16 points. So probably the least important station, but also again should be quite. It is incredibly important to have some idea, overview of the main ethical principles, and it should be hopefully quite straightforward for most of you. So yeah, good advice is just going through the GMC good medical practice. And, knowing your 5 ethical principles, autonomy, beneficence, non-maleficence, and justice. I'm not sure what the 5th one is. I think there is a 5th one. But, just knowing those inside out. So patient safety is always going to be the priority. You want to think about what other kind of secondary issues are raised. So confidentiality or consent, for example. Applying the medical ethics principles. And, how you would, potentially resolve the issue in the least kind of invasive way and the most kind of, direct way before you escalate it to higher channels. And, what extra information would you want to gather to clarify some of the ethical issues? So I've just kind of picked a few things that I think, it's just good to have revision about. So capacity is one. So always assume a patient has capacity. So I think unless there's something obvious that makes me think, oh, I need to assess this patient's capacity, assume it, and take all the steps you can to ensure that you're optimizing that decision, that assessment. Just because a patient is making a bad decision doesn't mean they lack capacity. So if you're struggling to ascertain a patient's capacity, you might want to involve other professionals, such as a speech and language therapist, because they might be dysphasic, for example. You might want to seek advice from their relatives or from the mental health team. You also want to know if they lack capacity, whether they have made any advanced directives or if they have someone they've allocated as their lasting power of attorney. And if there is no one to represent the patient, no friend or relative, you may want to involve an independent mental capacity advocate to represent the patient. And ultimately, you always want to act in the patient's best interest if they do lack capacity. So just remember that a patient has to be able to do 4 things to show that they have capacity, and that's that they can understand the information that you're giving them, they can communicate it back to you, and they can retain that information. So memory is not an issue, and that they can also weigh the risks and benefits. So often in clinical practice, it's number 4 that patients might not be able to demonstrate. And it should always be with regards to a specific decision. So for a patient to consent to something, they have to have capacity. The consent process should be informed. So it has to be started early. They should be presented with adequate information, including what the alternative is of not having the treatment or procedure. And it should be free from coercion. This shouldn't, hopefully, for IMT interviews, I don't think I doubt you will have a scenario involving guilt competence, because obviously you're applying to do adult medicine. But if they're under 16 years old, they can consent to a procedure, and that's called guilt competence. But if they refuse a procedure, this can be overruled if the procedure is in their best interest. And confidentiality is another big topic. So, it's implicit that most patients will understand that the information is going to be shared with other members of the clinical team. But I think in this scenario, you just need to be aware that there are certain situations where you might breach confidentiality, and that might be where there's a risk of harm to others. For example, if risk of tuberculosis exposure or HIV exposure, other communicable disease, particularly those that are of high consequence, and also if disclosure is required by law. And of course, if a patient consents for their confidentiality to be breached for other purposes other than direct care. you may have a situation that, where they talk about end-of-life care. And I think just having an awareness that if someone has like an underlying physiological process that is not reversible, sometimes the kind thing to do is to not continue treatments that are going to cause them unnecessary distress. And ceilings of care are really important to discuss. But again, I doubt this is going to be something that comes up for a 5-minute station, because it's quite a lot shorter compared to previous stations we had. So again, just being basically a sensible, safe, ethical doctor. Nothing, again, no rocket science here. So these are just some examples. So another seizure case, actually. So you're an FY2 in GP and a patient previously admitted to A&E last week with a seizure attends for follow-up. And you suspect the patient may have driven themselves. So, you want to gather information first and, ask the patient, is this what's, potentially what's going on? And do they understand, firstly, what the GBLA guidance is? Because it may well be that they're not aware of that. If they actually actively refuse to stop driving, then this is a situation where you do need to breach confidentiality. Inebriated colleague. So yeah, I mean, you're FY1 in general medicine, probably not in this scenario because you probably be the IMT. And your IMT2 has arrived on the ward, slurring the speech and making inappropriate remarks towards nursing staff. So I think in this situation, you would have a direct conversation with the IMT2. I don't think they would be safe to continue working. And, if it was a recurrent issue, you may want to escalate it to supervisors. But I think the immediate issue is patient safety. And yeah, you're the F1 on Jerry's, and notice a fellow colleague has posted on Twitter a joke about a patient who's been delirious during your shift. So again, I think, you want to directly raise this with your colleague and give them an opportunity to rectify their actions, especially when there's patient identifiable information being shared online. Here are some other potential scenarios or issues that might come up. So when it comes to mistakes, don't forget duty of candor. So you should always, that you have a duty to actually tell the patient about the error, regardless of whether it had any consequence or not. Okay, so that brings us to the end of the presentation. So if anyone has anything they want to ask about any aspect of the interview or IMT, feel free to. And thank you all for coming. We appreciate you taking time out of your evenings, and I'm sure you'll do really well. So good luck, everyone. I'll just end this presentation. No problem. I don't think you have to bring any evidence of your achievements to the interview anymore. So it's really, really, really brief. It's actually crazy how quickly it goes by. And I think it's now all very because it's a bit like an OSCE. They're very pre-specified questions they have to go through. It's very unlikely they'll ask you to bring any further evidence. But you should be prepared to talk about things in your portfolio. Yeah, Michelle, no problem. We're going to send out a PDF of the whole presentation.
Someone said, please, could you go through the scoring for the first station?
Oh, Jess, shall I bring up the slides for that?
I've got it up if you want.
All right. And you know what's really interesting is that I know so you have to get a good enough application score to get an interview, but your actual IMT ranking is 100% interview. But it's almost a bit of, the more you have on your portfolio, the more you can talk about in station one, which constitutes like 50% or so of it. Like it all kind of feeds in, doesn't it? So like,
yeah. So if you have a good portfolio, you probably will do quite well in the station. Though a lot of it depends on how you sell yourself.
Yeah.
So you have to have good communication as well. So even if you have a great portfolio, but you can't communicate that well, or if you don't have a great portfolio, but you can really sell yourself, I think, but the chances are, if you have things to talk about, it will reflect in your score.
Yeah. And somebody said, there's no daft questions, don't worry. If my portfolio is lacking IMT content, radiology/surgery heavy, do you have any advice for the first station?
I think, I think everything is relevant in medicine, isn't it? Because having skills in different areas, is really useful. But I think, first I have to ask you if IMT is there a reason that your portfolio is heavy in these other areas, and is there a reason why you have applied to IMT, and they probably will want you to justify that, and was there a change of heart, and what was that? Because people do change their career paths.
Would you say, Anna, you mentioned before about obviously IMT is a relatively broad step to then go on to sort of a physician-based specialty. This person saying radiology surgery, but you don't necessarily have to know, oh, I want to become a dermatologist or I want to become a cardiologist. They would just want to see that you're, interested in a career towards medicine, right? So
yeah, exactly. I'm sure anything that you've done that is radiology or surgery related can have a medicine slant.
Yeah.
Of how broad it is. And anyway, if it's mainly to just see, most of your portfolio stuff is just to see, have you engaged with QI processes? Okay, good. So I would talk about how you really enjoyed cardiology, and actually, you came to it quite late, but actually radiology is potentially really, if you have good radiology related stuff, a lot of cardiology, involves interventional procedures and also imaging is now another subspecialty. And but I think even saying that, you realized you wanted to apply to medicine a bit later is actually really nice, and it's fine. I think, to be honest, I don't know why. I think we need as many internal medicine trainees as possible, and
we do. We need more IMTs.
All of you should get a job, and the chances are all of you will get a job in the region you want. I think the interview is just a way to maximize the chances of you getting your top choice, really.
And would you say, Anna, that you said that IMTs become more competitive? I think I looked and there was about 4,000 applicants for the last year's round, but that's not the people aren't just applying to IMT. Like surely there'll be some people maybe applying to GP or other specialties. So you shouldn't be kind of fazed by that, right?
Yeah, some people do spread their eggs in lots of baskets.
Sure, yeah.
And that number alone doesn't really reflect the numbers that. So say, if you're in London, then it's going to be competitive wherever whatever you apply to. But generally outside London, you probably get a job in the deanery you want, even if your interview score is not the best. Even if you're in the 50th percentile or whatever, you probably will get a job. Yeah, because the competition ratios vary quite dramatically with the region.
Okay.
But having said that, I think now, I think IMT is pretty much filled up in round 1. I can't remember if they had a round 2 last year. So
I don't think they did. And round 1 is that. So round 2 is if they don't fill all the national training numbers, right?
yeah.
But they did. They filled all of them.
And
So
traditionally, IMT never filled national training numbers. I think in the past it used to be like 60%.
Really?
Which, and I think it's a multiple factors contribute to that.
Okay.
Yeah.
And somebody said, I think you mentioned medical school performance within the first station. So what do they look at within that? And I think the reason why we put that in was because when you do your shortlisting score, I think it asks if you've had a sort of a distinction in one of your exams or if you graduated with honours. And I suppose you could say that as part of one of your achievements, and that this demonstrates that I am a hard worker and that I've achieved academic. You could really sell yourself and say I've achieved academic excellence, which is what they want.
I think, yeah, I know it's there's no right way of doing this, but I think
just back yourself. Like you've got an interview, back yourself.
Yeah, you've got to sell it. Yeah.
Sell yourself. You'll be fine. And is it better to have an end specialty in mind? I suppose dermatology or respiratory, some people go into IMT knowing exactly what they want to do. And I suppose the fact that you're saying, I'm really committed to achieving this goal in terms of my career would be fine, but you wouldn't be at a disadvantage, right? If you didn't.
No, absolutely not.
Yeah.
Absolutely not. Yeah, I mean, a lot of IMTs actually don't know what they want to do post IMT, but they're just interested in medicine as a whole. I wouldn't say it's better either way. I think if you do have an interest, then mention it.
Somebody said, how will they have access to our portfolio? Can they access my JRCP?
This is nothing. So the interview is purely based on, it's just all the scoring for the interview is based on the conversation they have with you over that time period. So they're not going to be looking at anything else.
But anything that so say like if you've said, I've done a 12-week teaching program and you max out on the teaching points, can they ask for and then you mention that in station 1, can they ask, do you have to provide sort of a certificate or a letter confirming that, or
no?
So they're just trusting you that you're being honest, and I suppose they could ask you, right? Yeah. So you wouldn't.
I think basically, like in the past, they actually did look through the portfolio,
right?
And they marked how fidel, I guess, you were to whatever you said you self-assessed on.
Yeah.
Well, I don't think they can do that now, given the volume of applications.
Okay.
I don't think there's any kind of. I think they've said that they will randomly pick some trainees to show their portfolio. But yeah, I mean, it's relying on your honesty. But it will come out in the interview if they ask you about something that you've written in your application, and you can't, justify it or explain what you've done, then it's going to come out. And I mean, I hope that most trainees are not going to lie about what they've done.
No. And anything that you have done, as you were saying before, Anna, it's just about making sure you can demonstrate how that's transferable to an IMT, and it's very broad. Like anything you've done, like you said, whether it's in medicine or outside, if you were, I don't know, volunteered through a charity or something, it's all transferable. Teamwork, leadership, good communication. They want all of that, don't they? So you've just got to
say soft skills. I think they want to see that you're not just someone who's got a great CV, but you're someone who is someone who has those softer and more emotional intelligence, because you do have to have quite a lot of that as a medical trainee.
Yeah.
Yeah, and really good comm skills.
Perfect.
I was also just going to say, so also for evidence, if they wanted you to provide evidence for anything, they would have contacted you already to upload it onto Oriel. It's very few people that ever get asked to do that. It's 1 out of every 200.
I imagine that the people they're probably asking to contacting for evidence are those who have potentially very high scores, maybe. I don't know what their cutoff was for the interview this year, though.
Yeah. I mean, I don't know anyone that's been contacted to upload things, but I think somewhere it says that you might be contacted ahead of time, but that window has also passed, so they won't ask you now.
But I think the prospect of being potentially asked means that people have, you know, they can't, they're not going to just put anything on the application.
Yeah,
They'll probably just randomly like check, you know, like a quota.
Because I reckon if they did, if you were selected and you didn't have the evidence to back it up, I think that would disqualify you from the whole process.
Yeah.
Yeah,
for sure. Yeah. No, everyone will be good. You'll get your IMT.
Yeah, you guys are here at like 8 o'clock on
You're
Wednesday
motivated.
night, but you're gonna be fine.
This shows commitment. You've attended a Mind the Bleep.
And honestly, we want IMT trainees.
Yeah.
And yeah, like I mean, you've already expressed an interest in wanting to do medicine, so like already you're doing really well. I mean, you know, kudos to you. It's one of the toughest training programs, I think. So, you know, it should be the other way around. They should be, you know, you should be interviewing them. Why should I join your deanery? But you know, this is how the situation we're in.
And somebody said about neurology being my endpoint. And the thing is, if you're passionate about a specialty, and you know that will shine through. And I think, you know, that's what we need, different specialists, don't we? Everyone finds what they enjoy, and I think, yeah, that's great if you know. But
yeah, IMT is definitely a stepping stone. And remember that neurology has now become a Group 1 specialty. So you know there is you know, GIM. They want to see that you can do GIM as well. Unfortunately, I think for neurologists, but yeah, you know, nothing else to comment really.
No, I think, yeah, most specialties. I think dermatology is still holding out to not be gen med, but I wonder. Yeah,
I think I doubt. I don't think that's happening anytime soon.
No, yeah, love dermatology. Cool. Right. I don't think we've got any more questions. They need more med regs. We do.
Yeah, and no words. I mean, they need a lot more people in medicine, to be honest. And yeah, you know, yeah, you guys will get a job. Don't worry. Like it's.
What we can do is we'll send out the PDFs. I don't know, Anush, how the best way to do that. Is there a way of just sending it out to all the emails registered, or?
I think the best way to do it is probably put it on the event page.
Oh, on Facebook.
Yeah.
All right. Yeah, we can do that. Fine. Derm Reg hoping for SGS on the take.
Yeah, that's not gonna happen.
No, there's definitely a lot of acute dermatology I've seen as an F1 already. But yeah. Cool. Right. I hope everyone enjoyed that. Do you recommend any study material, as my interview is in 2 weeks?
There are lots of different resources. So if you just, you know, Google IMT interview prep, but unfortunately a lot of them do, like, you have to pay for them, which is potential barrier for some people. I would study the slides that we've sent out as well and practice with other people. And there's one book that traditionally a lot of people used. What's called Interviews for...
Oh, is it the Interviews for Healthcare Professionals or something?
Yeah, the one that's black and white and
medical interviews.
Really yeah, sorry. So I did use that when I was preparing, but I think it's probably a bit too much detail, to be honest, for IMT interviews.
Okay.
I'd say IMT interviews are actually a lot more straightforward than that book presents. So you will end up like over preparing for it potentially if you go through every question in that book.
And the study material, just, I know we've mentioned about the clinical cases. I suppose you could think back to like, what are the core things that you would see in medicine? So like, I suppose shortness of breath, it could be a scenario, or chest pain, or really common things. They're not going to put in like some really, like, it's not going to be a PACES scenario, is it? It's going to be...
No, it's not going to be PACES. It's going to be like, it's going to be like finals OSCE 2.0.
Yeah, just think of it as like, how did you prepare for that? I think that's probably.
And it's going to be all very pragmatic stuff, and it. But yeah, so but one other way you might be able to just look to potential things that might come up is maybe research the IMT curriculum. They actually have a list of like presentations within that they expect like all IMTs will encounter during their training years. So if you just scroll through it, but I really wouldn't stress about the clinical station. I would really focus your preparation on station 1, which is like more than half your entire score. Your baseline clinical knowledge is probably already very good, and definitely good enough for the interview. Remember that they're not expecting you to act at like the level of a registrar. You have to just have a good basic approach. Yeah.
And they're just wanting to make sure you're safe, right? They're thinking, if this person was my IMT1 and they've recognized that this person is acutely unwell and they're escalating, what more, as long as you're safe and you're seeking support where needed.
Exactly. 100%. Yeah.
Any other questions from anyone? And yeah, I'll put the PDF on the event page now, and we can upload this recording.
Yeah. It'd be awkward watching myself back, but
no, good.
Thank you all so much for coming and engaging with us. Really appreciate it.
Good luck, everyone. You'll be great.
You're gonna be great.
Have faith. You'll be good.
Honestly, the interview will be so much more straightforward than you imagine, and so much more it'll go by so fast, and it's just so they're not gonna try and trick you, like catch you out or anything like that.
Perfect.